Welcome to Catholic Ethics and the Challenge of COVID-19, a live webcast series presented by the Catholic Health Association and Georgetown University in cooperation with the Pellegrino Center for Clinical Bioethics. Thank you for joining us. My name is Kai Taylor, and I will be the operator for today's presentation. Before we get started, I would like to acquaint you with a few features of this web event technology. At any time, you may adjust your audio using your computer's volume settings. There will be a question and answer portion of the webinar. To submit a question, just click on the Q&A icon on the bottom toolbar of the Zoom platform and enter your question. Please note that today's presentation is being recorded, and both the recording and slides will be emailed to you. We are joined today by Brian Kane, Director, Ethics for the Catholic Health Association. At this time, I would like to turn the presentation over to Brian for opening remarks. The floor is yours, Brian.
Good day, and thank you all for joining us for part 8 of this special series presented by the Catholic Health Association and Georgetown University entitled Catholic Ethics and the Challenge of COVID-19. Before I introduce today's speakers, let us pause to reflect on this blessing for healthcare workers in a pandemic. Blessed are the ones who cannot be isolated. Blessed are all the healthcare workers. Blessed are the hands that are raw from scrubbing and sanitizing, and the hands for healing, comforting, and supporting. Blessed are the shoulders that carry the weight of life and death. Blessed are the feet that are aching from standing at the bedside, running between rooms and answering phones. Blessed are the hearts that are frightened and breaking. Blessed are the mothers and the fathers, grandmothers and grandfathers, sisters and brothers, partners and friends who cannot go home. Blessed are the families who become isolated from each other, the ones who sacrifice their own comfort so that others need not be alone in their suffering. Blessed are the sick and the dying, those who bear the image of God before us. Blessed are those who look upon their work as sacred and as a gift at this time of overwhelming demand. Blessed are those who lack the space to process all of what lies ahead, and may others bear their burden with them. Blessed are the ones who are found weeping in corners of our emergency rooms, our hospitals, primary cares, our outpatient centers, so that we might see a strong face to greet our need. Blessed are those who weep openly with us, so that even our tears have companions. Bless you, O God, quietly holding each of us along the way. Come quickly, abide unceasingly. Love us while we see the worst, and give us the hope to do our best and continue our mission with compassionate care. Amen. We're very honored today to be joined by two distinguished guests from Georgetown University who will focus on the ethical issues related to COVID-19 and the elderly. Dr. Miles Sheehan is a Jesuit priest, physician, and lecturer at the Pellegrino Center for Clinical Bioethics. Trained in internal medicine and geriatrics, he practiced in these fields and served until 2009 as the Senior Associate Dean at Loyola University Chicago's Stritch School of Medicine and the Ralph P. Leischner Professor and Chair of the Leischner Institute for Medical Education. From 2009 to 2014, Father Sheehan was the provincial for the New England province of the Society of Jesus, and since 2015, he has served as the provincial delegate for senior Jesuits for the Maryland and the USA Northeast provinces of the Society of Jesus. His interests include end-of-life care, care of older persons, spirituality and healthcare, and medical education. And moderating our discussion today is Dr. G. Kevin Donovan, who serves as the director of the Pellegrino Center for Clinical Bioethics at Georgetown University Medical School, as well as a professor of pediatrics at the university. Dr. Donovan is a clinician ethicist with more than 30 years of experience in the field. Welcome to you both. Today's event is 30 minutes. If you have any questions for the speakers, please go ahead and enter them in the Q&A module, and they will be answered as time permits. I now turn it over to Dr. Sheehan and Donovan to begin the discussion. Welcome.
Thank you, Brian, and thank you, Dr. Sheehan, for being with us today. I want to point out something Brian already mentioned, that Dr. Sheehan is exceptionally well qualified to consider these issues, both as a bioethicist and as a physician who has special training and a great deal of experience in geriatrics. So, Dr. Sheehan, I know that we're going to be talking about several of the ethical issues with the elderly during this pandemic. The issue of resource allocation will be mentioned, but I will point out to everyone that that was covered in a previous presentation. So from there on, would you lead us into it, Dr. Sheehan?
Sure, if we can have the next slide, please. As Dr. Donovan mentioned, what we're going to focus on is in particular the issues that COVID-19 has had and the ethical perspective regarding the problems that have been evident in long-term care and the isolation of older persons. Before we go into that, I'd like to talk a little bit about some of the basic aspects of geriatrics that perhaps influence the impact of COVID-19 in an older population. We're going to be talking about some big policy decisions as well as individual ethical decisions. And so it's important to try and keep those two things alive in your mind, as well as focusing on what it is that you can do and not just feel paralyzed about the big policy issues. It's also important to consider why the nursing home population has been disproportionately affected. And my hope is that for those who are listening, that you will have the opportunity in your own work in long-term care and care of the elderly to review on this, to reflect, discern, and plan for the future. Next slide, please. Now, one of the things that is very clear is that good clinical ethics depends on good medicine. And when I was practicing geriatrics, it really is important to realize that aging is a marker for diversity. The older people get, the less alike they are. So you could have two 90-year-olds, one is in a very frail condition, the other very active, very alive. As a general statement though, aging does contribute to the loss of functional reserve in key organ systems. So we talk about the lungs, the immune system, the kidneys, and the cardiac system. And that means that older individuals can be more vulnerable to insults that might not be as dangerous for younger persons. In other words, what might be a relatively small infection in an older person can turn out to be fatal when a younger person would shake it off without much effect. COVID-19 infections have disproportionately impacted the elderly and the minority communities. The changes that I mentioned above are probably part of the reason for the elderly being disproportionately impacted, as well as the close quarters they share within long-term care. Within minority communities, there are many issues, including the effects of structural racism on healthcare in our country. I'm not going to be considering those in this particular discussion as our focus is on the elderly. However, it is important to notice the disproportionate effect that's happened to people of color with the COVID-19 epidemic. Now, back to the aging population. Age is just a marker, and some older persons are quite robust and do well despite infection. Next slide, please. So where's the ethics on this? At a very basic level, we're talking about the value of life and human dignity in a special population, one that's vulnerable because of some general medical processes, as well as the way in which this vulnerable population is housed together. What is ethics about? Well, if you like your Aristotle and the Nicomachean Ethics, and if you're having trouble sleeping, I recommend that. It's actually wonderful. But ethics is about aiming for the good. How do we best protect the elderly? Avoid policies that devalue their lives, and how do we show care for them as persons in environments that are safe and encourage the best possible life? As I was preparing this talk, I did feel myself overwhelmed about some of the big macro issues. But I think a prudent person who has responsibility for long-term care will seek justice for the residents. In other words, give people what they're due, to act courageously to create a safe environment, and then show the virtue of temperance, that is restraint in decision-making, both avoiding laxity as well as overly protective policies. Dr. Donovan, you're muted.
Well, the little button didn't work. Sorry. When you talk about overly protective policies,
We're going to be talking more about that when we get to looking at the isolation of the elderly in this, and to consider other ways in which we can perhaps allow more contact for older people and their families.
Is it a matter of contact, or are there other unnecessary restrictions on their personal freedoms as well?
I honestly don't know in this setting. I think probably the lack of socialization within the community and other personal actions right now are very difficult, but we'll talk more about that. Now, what happened? This is an article from Forbes that I got online, and it said that 2.1 million Americans are only a little over 0.6% of the US population, and they reside in nursing homes and assisted living facilities. But as of about 3 weeks ago, and I don't have data since then, an astounding 42% of the COVID-19 deaths have taken place in nursing homes and assisted living facilities. That is, 42% of the deaths are taking place in facilities that house less than 1% of the population, and that is probably an undercount. Part of the reason for this is some states like New York, New Jersey, and Michigan, at the height of the pandemic, ordered nursing homes to accept patients with active COVID-19 infections who were being discharged from hospitals. Next slide. Now, why is a nursing home or a long-term care setting such a dangerous place? Well, many of the rooms are shared, double and sometimes 4 people in a room. Bathrooms as well are shared. As I mentioned a moment ago, it can be difficult to socially distance in common areas as well as the dining rooms. When the pandemic began and continuing for a while, many nursing facilities had a lack of personal protective equipment for the caregivers there. Those caregivers themselves, who are usually not extraordinarily well paid, let's put it that way, often were in financial stress and need to work at multiple facilities, thus making them possible vectors of transmission between different long-term care settings. At the same time, one wonders about how strict people were adhering to infection control in these centers, as well as, at least initially, the lack of testing. So you didn't know who had it, who didn't, who might be bringing it in. As I mentioned before, the policies in some states that required COVID-19 positive patients to be sent to long-term care facilities, the forced transfers, I believe, are not happening. However, in many governance areas, there is enhanced reimbursement for facilities to take new residents who are COVID-19 positive. That's problematic. ProPublica, again online in May 29th, mentioned that the long-term care industry had resisted a federal mandate to plan for disasters, including pandemics. This came out at the end of the Obama administration. About 43% of the nursing homes have been caught violating the requirement, including facilities that have had COVID-19 outbreaks. The American Healthcare Association, which is the trade association for many long-term care facilities, says that preparing our health system for future outbreaks, more regulation is not always the answer. There will be time to look back and determine what we can do better for future pandemics or crises. And here's the point: the authors of the ProPublica piece were saying that the regulations weren't followed and that there were a number of problems. The American Healthcare Association says that the burden of the regulations is part of the problem, and we need to look and see how we can do better in the future. Next slide, please. If you have a chance, I would encourage folks to take a look at this article from the New England Journal of Medicine, and so the slide has the complete reference. It says that nursing homes were unstable even before the COVID epidemic hit, but they were like tinderboxes. And although major regulatory processes have attempted to address deficiencies in the quality of care, COVID-19 has shown better monitoring is not enough. The coronavirus has exposed and amplified a long-standing, longer and larger problem: our failure to value and invest in a safe and effective long-term care system. COVID-19 has exposed the cracks in our tenuous system of providing and funding long-term care. There are no easy fixes. But we believe we're well past due for comprehensive policies that take care of aging Americans seriously and in a wider range of settings. Beyond the pandemics, and this is the part where things get big and sometimes difficult to face as individuals, we have to transform the way we pay for and provide long-term care. And the authors say Medicaid programs need to invest more in care in all settings, need safe, affordable residential options, and finally, a major reconsideration of our piecemeal approach to paying for long-term care. Next slide, please.
Dr. Sheehan, you did talk about the wider range of settings. Are you also thinking about the estimated 6 million people who are trying to manage with paid home care is included in that wider range?
Yes, absolutely. And again, the articles in, I don't know if it was the New York Times or the Washington Post, about home care workers having a particularly difficult job because, again, they often have to travel to different homes, raising the possibility their ability to acquire personal protective equipment is limited. The individuals for whom they care are in, often really, really need the help. So again, can we look at how we can protect the workers and protect the individuals and develop a home care system where the people who provide the care are well paid, well trained, and that the people who receive the care are safe?
Do you think there's also a focus on making the people who work in these facilities part-time rather than full-time, simply to save money on things like benefits?
Of course, of course. I mean, this is the part that we need to talk about. When we value life, it has a cost, and that I do not know the answers as to how we will pay for these things. But I do know that for many Americans, paying for excellent care for their older relatives is almost impossible. As we think about the appropriate ethical response, I think we do need to look at the macro policy level and the level of individual institutions. Now, that business about sending COVID-19 patients to nursing homes, at the point that that was happening, hospitals, particularly in the New York area, were terrified about being overwhelmed and not having beds. We really shouldn't repeat that. And great care now must be taken and accepted COVID-19 patients from hospitals. If facilities are accepting these patients because of enhanced reimbursement, I really would hope that they are facilities that have excellent records with infection control, the ability to appropriately isolate these persons from other vulnerable residents, and that they have dedicated staff just for those residents so that they're not transferring at least the possibility of infection from one group to another. Now, the other thing when we talk about funding of long-term care, this business about 4 people in a room has to end. It's a setup, the way in which we physically have structured our nursing homes. The facilities we have now, we can't redo them overnight. But again, the thought about sharing my room with 3 other people when I'm an old man and having to share that bathroom, I don't view that as part of respecting the dignity of anybody. We need to look at not regulation as a reflexive way, but is there a way in which we can work to have regulations that are meaningful, not simply bureaucratic checklists, and will make a difference? And finally, to make sure that staff get funded, that they're paid enough so that they don't work at multiple facilities. Now, the folks who work in long-term care, the immediate thing now is to make sure you're fully stocked up on PPE, that you have aggressive testing protocols, that you have strict infectious disease policies. As we are seeing some reduction in at least parts of the country in the COVID-19 rate, we need to be ready for when this comes back. Right now, it looks like it's quite high in some parts of the country, and with decreases in social distancing over the Memorial Day weekend, as well as individuals who are protesting who might spread it to older people, We really need to be ready for a second wave. That is the most important ethical point I could make right now. Next slide, please. And here's another thing. As I was preparing this, next slide, please.
Yep.
As I was preparing this, it struck me at how used we are that there are always high death rates in long-term care every year from influenza. Why have we been complacent about that? You say, well, we haven't been complacent. We made sure people got immunized and all that. Yeah, but I don't think we've done enough. And I think that this fear, an appropriate one, because we've been badly burned from COVID-19, that if we prepare for a second wave infection, it means that we look and accept the responsibility to institute best practices to prevent not only COVID-19, but the other infectious diseases that are regrettably common in long-term care facilities, like influenza, C. difficile, MRSA, VRE. Those are, for folks who don't know, those are kinds of resistant bacteria. Again, you can do a lot with vigorous washing, with face masks, with general sanitation. And that doesn't require a huge public policy shift. It requires determination at a local level.
Do you think that some of the issues with infection control and the excess deaths from influenza were taken in stride because they at that time primarily were occurring in places like nursing homes and long-term care facilities?
Yeah, I mean, it's one thing to say that older people are more vulnerable because some of the changes that happen generally across the population, but I think that made us complacent, and that we didn't pay attention to the ways in which we really could limit spread of other infectious diseases, and have not been as scrupulous as we can be about vigorous infection control. There always will be, regrettably, because of the vulnerability of some elderly from the physiologic changes that commonly occur with aging, to diseases like influenza. So there will be, as we say, an excess mortality rate among the elderly. However, that rate, I believe, could be reduced if we take the lessons of COVID-19 and continue to be extremely aggressive on the best infectious disease control policies possible.
So it's about infection, but it's also about ethics.
Right. In other words, we have a duty to care. We have a duty to respect life. If the place isn't clean, then we're not respecting life. Now, this shifts to another topic that, Kevin, you knew when I was talking about to you. A number of Jesuits in the community here, we've been saying, I'm so glad my parents aren't alive now. And that might sound terrible. I love my parents very much and I miss them. But I can't imagine what it would have been like to be caring for my mother if she was isolated and I couldn't visit her. I don't know what it would have been like for her. And we have now many older people in long-term care and their families who have forced separation. I understand the emergency was absolutely necessary as we were trying to get a handle on it. But here's the part where, can we now look at alternatives with prudence, mitigating the risk? I'm not talking about open things up and being silly. I can only imagine that some older people in long-term care don't feel life is worth living if they can't interact with their children and their grandchildren, those people who they love. Our ethical responsibility is not only to preserve life, but for those who provide care to try to permit lives to flourish, to have the best possible life. How do we got to think about this? This is a part where I would encourage those who are participating to think broadly and creatively. Perhaps have visits outside the facility. Now, it's going to get too hot in some parts of the country to do that. But we will have some nice days where visitors could be outside. Would it be possible to get rapid COVID-19 testing for family members, realizing that that won't be 100%? But I think we need to think about, is it worth the risk so that people aren't dying out of loneliness and depression? And again, without the interaction from family members, perhaps getting increasingly confused and losing cognitive ability. Can we be creative with technical support for residents? And I read this in a newspaper article, and I can't remember where it was, so I'm stealing it, and I apologize for that. My idea is, you know, that say we don't have anybody who's good at tech in a nursing home. Well, hire a student 2 or 3 hours a day for he or she to be able to help out. You know, buy a few iPads. FaceTime is easy. I'm sure you have your own great ideas for this, but this is the part where ethics, attending to very nitty-gritty things, requires creativity and not simply accepting the status quo. We needed to isolate, and we will need to isolate in some circumstances to reduce the risk of infection. But can we be creative so that we can reduce the risk of loneliness and taking away the joy out of the lives of many of our older residents?
Dr. Sheehan, what you've just hit on was a major point for a lot of the listeners and attendees, and I think it's extremely important. There were a couple of other things that have already been raised that I think maybe we can touch on even before you summarize your talk. And one of them is the fact that you brought up the important to consider and push the envelope on about the rooms, respecting the dignity of the individuals. Isn't this all going to really mean that we're going to have to find ways to influence the reimbursement models so that this can be realized?
Yeah, we'll need to influence the reimbursement models, and that's going to be, you know, a heavy push in the next year where so many different things will be happening. But it is the kind of thing that I think needs to be done, that the living conditions in which we put our elderly are not the kind of conditions we would want to have. And really, we do need to look at this from a perspective of human dignity and from a perspective of infection control. Just to summarize, issues with long-term care, isolation of the elderly, and allocation decisions have been part of the ethical concerns in the COVID-19 pandemic. Those who want to exercise the virtue of prudence will focus on changes of long-term care that will enhance infection control, limit spread, prepare for a possible second wave, and also decrease common rates of infectious disease problems. Creativity is called for now to safely decrease, or to decrease safely, the isolation of residents in long-term care while mitigating the risk of new COVID-19 infections. Now, these things about redoing our reimbursement model, that can seem daunting, but there are issues of justice and respect for human dignity that can be attended to now. And there's a call to re-examine how we care for our most vulnerable older population.
There have been a couple of other questions that have been raised that have been touched on perhaps, but maybe you'd like to expand on in the last couple of minutes that we have left. One of them was specifically addressed towards an age bias, talking about physicians having perhaps an age bias, which I think that maybe we ought to even expand that into, is there an age bias for more than just physicians? Is this a societal problem that really gets to the root of what you've been talking about?
Well, I think part of what we've been hearing with people going out and, you know, opening lockdowns, which I'm very sympathetic with, I'm sick of being locked up, but the point is, well, it's just old people get it and they're expendable. I don't believe older people are expendable when we can take actions to allow them to maintain their lives, and that we need to consider the risks for this older population when we look at issues as to how we work to control infectious diseases for which we don't have a treatment. So it's not just ageism among doctors, which exists, but it's, I think, a larger ageism among the larger population.
Well, that is a problem that at least could be addressed without without fixing all the financial problems that also plague the long-term care situation.
Yeah.
I'm not sure. I'm not sure we're going to be able to fix it any faster, but I think that it's one of the root causes that deserves some attention as well. I haven't gotten another question right now, and I think that our time is just about up. So I would like to thank you for what I think was a really great presentation with great insights. So thank you, Dr. Miles Sheehan, for that.
Thanks, Dr. Donovan.
I can remind everybody that there'll be another session in a week and on ethical issues in the COVID pandemic that will be parallel to this in that it will focus on the disabled. Thank you.
On behalf of the Catholic Health Association and Georgetown University, I would like to thank you for participating in today's event. The recording will be emailed and will also be posted on CHA's website at chausa.org. where you can also find recordings of previous sessions in this series. Today's program is copyright 2020 by the Catholic Health Association with all rights reserved. This concludes today's program. Thank you and have a great day.